Okay, so today we're going to talk about types of IV delivery systems. So types of venous access include safe and reliable for infusions. It is a critical component of patient care in the acute and community health settings. There's a variety of options available, and the venous access device needs to be selected based on the duration of the IV therapy and the type of medication or solution to be infused. It also needs to meet the needs of the patient. And in practice, it is important to understand the options of appropriate devices available. This selection will describe the two types of venous access, peripheral IVs accesses and central venous catheters. These are the two that you will see most commonly. So first, peripheral IV. A peripheral IV is a common preferred method for short-term IV therapy in the hospital setting. It's also used in home care for quick infusions, infusions that, like if we're doing specialty infusion like IgGs and things like that. A peripheral IV or a PIV is a short intravenous catheter inserted by percutaneous venipuncture into a peripheral vein, held in place with a sterile, transparent dressing to keep the site sterile and prevent accidental dislodgement. Upper extremities, hands and arms, are the preferred sites for insertion by a specially trained healthcare provider. We see these most commonly in the hand. We are seeing them in the antecubital region as well. And this is what you will be learning to start. So a PIV. If a lower extremity is used, remove the peripheral IV and re-site in the upper extremities as soon as possible. And this is from the CDC. The hub of a short intravenous catheter is usually attached to an IV extension tubing with a positive pressure cap. Now, sometimes in an emergency situation, they will put a PIV in a leg or wherever they can get. But as soon as you are able, you must move that to an upper extremity. So PIVs are used for infusions under 6 days and for solutions that are osmotic or near isoosmotic. They are easy to monitor and can be inserted at the bedside. CDC recommends that PIVs be replaced every 72 to 96 hours to prevent infection and phlebitis in adults. Most agencies require training to initiate IV therapy, but the care and preparation of equipment and the maintenance of an IV system can be completed each shift by the trained healthcare provider. So PIVs are prone to phlebitis and infection and should be removed when those are noted or every 72 or 96 hours in PRN. As soon as the patient is stable and no longer requires IV fluid therapy, as soon as the patient is stable following insertion of a cannula in an area of flexion, immediately if tenderness, swelling, redness, or purulent drainage occurs at the insertion site, when the administration set is changed, meaning the IV tubing. Now, as always, you follow your organization's policy. So let's talk about CVCs, or central venous catheters. They are also known as a central line or a central venous access device. And it is an intravenous catheter that is inserted into a large vein in the central circulation system. And this is where the tip of the catheter terminates or ends in the superior vena cava that leads to an area just above the right atrium. CVCs have become common in healthcare settings for patients who require IV medication administration and other IV treatment requirements. People go home with these all the time. They're known as PICC lines. So a CVC can remain in place for more than a year. Some CVC devices may be inserted at the bedside, while other central lines are inserted surgically. Central lines are inserted by a physician or specially trained healthcare provider. It's usually in interventional radiology now. Back in the day, we used to do them bedside, but we don't anymore. I mean, I used to even put PICC lines in the home and then send them for an x-ray, but we just don't do that anymore. They just go to interventional radiology, so there's no question of the placement. But when we did was, they did ultrasound guided placement as recommended to reduce time of insertion and complications. A CVC has many advantages over peripheral line, including the ability to deliver fluids or medications that would be overly irritating to peripheral veins, like vancomycin, and the ability to access multiple lumens to deliver multiple medications at the same time. Central venous catheters can be inserted percutaneously or surgically through the jugular, subclavian, or femoral veins, or via the chest or upper arm peripheral veins. So femoral veins are not recommended as the rate of infection is increased, as you can imagine why, being where that's located. To have a CVC inserted or removed, an order by a physician or a nurse practitioner may be obtained. Site selection for a CVC may be based on numerous factors, such as the condition of the patient's age, and the type and duration of the IV therapy. The majority of patients in an ICU will have a CVC to receive fluids and medications. A chest X-ray is given to determine correct placement before inserting or to confirm a suspected dislodgement. An IV pump must be used with all CVCs to prevent complications. Now, in home care settings, yes, we should use a pump, but that we don't always have a pump. So there are some workarounds that we can use when we're in the home environment. CVCs are typically inserted for patients requiring more than 6 days of IV therapy or who require anti-neoplastic medications, are seriously or chronically ill, like chemotherapy patients, require vesicant or irritant medications, again, like a vancomycin, a gentamicin, all the mycins, require toxic medications or multiple medications, require central venous pressure monitoring, like a Swan-Ganz, require long-term venous access or dialysis before like a shunt is placed or an AV fistula, require total parenteral nutrition, TPN, require medications with a pH greater of 9 or less than 5, or osmolality greater than 600 milliosmoles per liter, have poor vasculature, have had multiple PIV insertion attempts, 2 attempts by 2 different IV therapy practitioners. That's the INS guidelines. A central line is made up of lumens. A lumen is a small, hollow channel within the CVC tube. The CVC may have a single, double, triple, or quadruple lumens. Depending on the type of CVC, it may be internally or externally inserted and may have an open-ended or valved tip. Open-ended devices are those in which the catheter tip is open like a straw. These have higher risk of complications such as hemorrhage, air embolism, which you can understand why when they're so wide and so open. It's like blowing air through a straw. And occlusion from fibrin or clots. Valve devices are those in which the tip is configured with a 3-way pressure-activated valve. It is important to know what type of central line is being used, as this will impact how to care for and manage the equipment for specific procedures. So here we have 2 pictures. On the right is a single lumen. So this is a single lumen. Let me see if I can get my pointer. This is a single lumen. It's only got one entry. This is the tip that's leading all the way to that superior vena cava, and it's got 1 lumen. This here is a triple lumen. As you can see, there's 3 openings. Now, one tip leads to the superior vena cava, and inside this very narrow tube is 3 little tubes going in, and they all end at the same part. Now, what I want you to take note of here is there's 3 different colors. See, a white, a red, and a blue. The red is usually always used for blood withdrawals. It's the only thing that line is ever used for, because if it occludes because of the blood, if it clots, you still have 2 other lines. The white is usually used for your IV fluids, and your blue is usually used for your antibiotics or whatever else you may be infusing in. But as always, follow your agency policies. CVCs have specific protocols for accessing, flushing, disconnecting, and assessment. All healthcare providers require specialized training to care for, manage complications related to, and maintain CVCs per agency policy. Y'all are going to know that's my mantra by the time we're done. Per agency policy. Never access or use a central line for IV therapy unless trained per agency policy. Healthcare providers should assess a patient with a central line at the beginning and end of every shift and as needed. For example, now I do not think that you will be accessing these, but you need to be aware of what they are when you see them and you're taking care of patients. And again, it depends on your organizational policy. If the central line has been compromised, pulled, or kinked, ensure it is functioning correctly. Each assessment should include the type of CV, an insertion date, and the reason for it. The dressing, is it dry and intact? The lines, secured with stat locks, sutures, or steri strips? Does the patient still even require the CVC? Is the insertion site free from redness, pain, swelling? And is there a positive pressure cap? Is it attached securely? IV fluids running through an IV pump? Lumens, how many lumens are there and what is running through each? Does the patient have a fever? Are there any respiratory or cardiovascular indications of a possible fluid overload? These are the things that you will want to take note if you're assessing the patient. You may not be assessing the central venous catheter, but when you're assessing the patient, these are the things you will need to be aware of. So this is a percutaneous central venous catheter. And again, the tip of the catheter is located at the superior vena cava. So it goes in. It can either go in on the subclavian vein, or it can go into the internal jugular. Okay. And they end at the same spot, whether or not. A lot of times they do these in the emergency room, and these are done a little bit more for long term, like a Groshong or Hickman Broviac. And the peripheral inserted central catheter, or a PIC, again, still the tip is located at the superior vena cava, but a lot of times it is put in maybe at the antecubital. It just depends on where they find a spot. And then this is where you're going to assess for complications and access the device. So you're going to be monitoring this here. And then there's also the subcutaneous or tunneled central venous catheter. This is a tunneled CVC, also known as a Hickman, Broviac, or Groshong, and it's a long-term CVC with a proximal and tunneled subcutaneously from the insertion site and brought out through the skin at an exit site. So we start here. It ends at the same place as all the other lines, at the superior vena cava. However, it's tunneled subcutaneously and then comes out over here. So that is the only difference. So this was a quick lesson, but it was one that's of importance. You need to understand the different types of lines. You'll be working more with your peripheral IVs than you will your central venous lines. But again, depending on your policy of your organization, you might. But just be aware, as always, follow your agency policies.